called adrenal insufficiency, which of course is managed with glucocorticoid replacement. At 6 months follow-up, now her hydrocortisone has slowly been tapered. She's taking 10 milligrams in the morning, 5 milligrams early afternoon, and she's tolerating this regimen quite well. And she feels quite well. She has lost 25 pounds, her blood pressure and A1C is significantly improved, and she has also noticed some slight elevation in her LFTs. So then at 10-month follow-up, her 8 a.m. cortisol has improved to 11 micrograms per deciliter, and she's able to stop her glucocorticoid replacement therapy. So that brings us to today. So today is 1 year post-surgery follow-up. And now her 1 milligram dexamethasone suppression test that, remember, it started out at 10, has come down to 5. Still not perfect, but is improving. Her salivary cortisol has normalized, and her 24-hour urine-free cortisol is at 4 to 5, sort of right on the cusp. But her ACTH is still suppressed. So putting this picture together, she still has some recurrent hypercortisolism still. So that brings us to scene 1.
Good to see you again, Deanna. It's been about a year since your surgery now. How have you been feeling since our last visit?
Honestly, doctor, not great. I was doing better for a while after the surgery, but lately I just feel like I'm sliding back to where I started. The brain fog is back and I've been feeling pretty anxious again.
I'm sorry to hear that. Your symptoms have been improving. Are there other changes you've noticed?
Well, I'm not sleeping well, probably because I'm so anxious. And when I checked this week, I've gained almost 15 pounds, which is so frustrating after losing weight. Also, when I check my blood pressure at home, it's been high again. I'm just worried that the surgery didn't work.
I do see that your blood pressure was higher today, and your hemoglobin A1C is also increasing from 6.7 last visit to 8% now.
Yeah, I just don't get it. I've even been walking more, like we talked about, and I adjusted my diet.
I'm really glad to hear you've made some changes. That's great work.
Yeah, but what good does it do if everything's getting worse?
I understand how discouraging this must feel. Let's talk about your labs, because they will help explain what you're experiencing. Your overnight DST came back at 5. Now, that is better than before surgery when it was 10. But it's still well above our normal cutoff of 1.8. And your ACTH is still suppressed. All of this tells us the remaining adrenal tissue is still producing excess cortisol.
So the surgery didn't fix it completely?
It helped. We saw that with your initial improvement in blood pressure and blood sugar. But now your symptoms and your labs are both moving in the wrong direction. This tells us we need to take another step to manage the Cushing syndrome.
I see. So what are my options?
We could consider surgery on the other adrenal gland.
No, I'm sorry, but I don't want surgery again. After getting the adrenal insufficiency after my surgery and the time it takes to heal, I just don't want to go through that all again. Is there anything else that we can do?
Absolutely. I completely understand. Your concerns are very valid. There are medical treatments for Cushing syndrome, but it's important to understand that there is always a risk for adrenal insufficiency with surgery or medicine. The most important thing we can do is make sure you know what signs and symptoms to watch for, and that you have a clear plan for managing them.
I see. I still want to hear about the medications, if that's okay.
Of course. There are several medical treatment options that are available for adrenal Cushing syndrome that we can discuss.
So the ultimate goals of therapy in Cushing syndrome is pretty straightforward but critical. We want the treatment to be safe, quick, efficacious, permanent, acceptable to the patient, and feasible. And for adrenal Cushing syndrome or adrenal hypercortisolism, that often means adrenalectomy. For secondary causes like Cushing's disease, pituitary surgery, or ectopic source surgery for ectopic Cushing syndrome. But as all of you know, sometimes life is not that easy. So for adrenal hypercortisolism, we deal with both benign and malignant disease, unifocal and multifocal disease, often bilateral macro and micronodular adrenal disease. And with pituitary disease, Cushing's disease, persistent or recurrent Cushing's disease occurs in about 30% of the cases, and sometimes further surgery is not feasible, and you're also dealing with MR negative cases. And with ectopic Cushing syndromes, sometimes it's difficult to identify the primary tumor, or you may have metastatic disease. So when it comes to the diagnosis of Cushing syndrome, first, having an accurate diagnosis is crucial. And as you heard, we rely a lot on the low-dose dexamethasone suppression test. So a post-DST of 1.8 micrograms per deciliter is suggestive of hypercortisolism, but it has to be interpreted in the context of the ACTH level, which is when it's an adrenal source is suppressed, and the DHAS levels. So in the same way that measuring a calcium without knowing the PTH is not helpful, or measuring TSH without knowing T3 or T4, or measuring aldosterone without knowing the renin is not really that helpful, we need to interpret the post-DST cortisol in the context of ACTH. And certainly before we would consider surgery, we want to repeat the DST at least once, because as you all know, false positive DST levels are not uncommon. 24-hour urine-free cortisol and late-night salivary cortisol is normal in the vast majority of patients with adrenal hypercortisolism, but especially with those who have severe Cushing syndrome, it helps us to grade the disease severity. So it's helpful in that manner. So we use these tools not only to diagnose the hypercortisolism, to find out that it's an adrenal source, and to grade the disease severity. So now the big question is treating hypercortisolism. Why do we even bother about this in the first place? So in a recent article in Trends of Endocrinology, I compared the adrenalectomy to other commonly used operations, calculating absolute risk reduction and number needed to treat calculations with the mortality reduction from the intervention, as well as the quality of life effect. So look at this table. For colectomy, if surgery for colorectal cancer, stage 1 to 3, often saves lives. So if we don't operate on a patient with colorectal cancer untreated, the vast majority will die within 5 years. But if we treat those patients, meaning removing the cancer surgically, most patients will live. So the absolute risk reduction is 70%, with a number needed to treat of only 2, meaning for every 2 patients we operate, we save 1 life. And for severe Cushing, performing an adrenalectomy, the absolute risk reduction is 25%, with a number needed to treat, because we reduce the 5-year mortality untreated from 50% down to 10%. And of course, those patients have improved quality of life. And it's similar if you compare it to adrenalectomy for pheochromocytoma. And in fact, it compares favorably to operating on stage 1 and stage 2 breast cancer. So even for MAX, the absolute risk reduction is about 10 to 15%, with a number needed to treat of 7 to 10, and that's because of a beneficial effect on the cardiovascular and metabolic risk. And of course, on average, this patient's quality of life improves. And in fact, operating on MAX is pretty similar as operating on PA, where we reduce the cardiovascular and stroke mortality compared to maximum medical therapy. And it's similar to bariatric surgery for severe obesity, or an elective repair of a 5-centimeter AAA. And despite this, adrenalectomy is highly underutilized. And put differently, operating on patients with MAX is 10 to 100 times more effective in reducing the mortality than operating on an early stage thyroid cancer or ductal carcinoma in situ. So my point is not that we should abolish treatment of early stage thyroid cancer or breast cancer, but rather that we should take hypercortisolism and hyperaldosteronism much more seriously. There's various pathological subtypes of adrenal hypercortisolism. The classic patient has a unilateral cortisol-producing adenoma, but certainly some people have bilateral cortisol-producing adenomas, bilateral macronodular adrenal disease, micronodular adrenal disease where the lesions are a centimeter or smaller. The classic genetic phenotype is the PPNAD, where patients have severe Cushing syndrome from these tiny little pigmented tumors of the adrenal gland. And of course, sometimes we deal with cortisol-producing adrenocortical carcinoma as well. And the underlying mechanism of tumor development involve both germline mutations that are inherited and somatic mutations. And the common theme is activation of the protein kinase A pathway, the Wnt beta-catenin pathway, as well as mutations in the ARMC5 tumor suppressor gene and GNAS, as well as in bilateral macronodular disease, you have aberrant G protein coupled receptor expression. And all this has a downstream effect leading to adrenal cell proliferation and cortisol production. And one of the greatest advances is understanding the spectrum of adrenal hypercortisolism, not only the severe classic Cushing syndrome. So we can use, and this is very helpful explaining the disease to the patient, that we can grade it in mild, moderate, and severe based on the DST, but also factoring in signs and symptoms, other biochemical markers, and the time to diagnosis. So for instance, mild adrenal hypercortisolism often are detected by an adrenal incidentaloma. The biochemical indices are relatively mild, and often people have had this for years to decades. Whereas, of course, the signs and symptoms of the severe classic Cushing syndrome that we all know from the textbooks, the biochemical severity is much more pronounced, and the disease course is usually more rapid, so these patients tend to be diagnosed within months to years. And this spectrum of adrenal hypercortisolism also correlates with the common pathology, the underlying molecular genetics, and to some extent the target organ damage when it comes to cardiovascular morbidity and mortality, obesity, osteoporosis, depression, chronic kidney disease. And this has not been well studied, but we now realize that the prevalence of adrenal hypercortisolism is much more common than previously described. So for instance, in the general population, somewhere between 0.2 to 2% have adrenal hypercortisolism. And of course, the more severe disease you have, the severe Cushing's patients are less common. But if we look in the prevalence in high-risk populations, for instance, resistant hypertension or poorly controlled type 2 diabetes, the prevalence of hypercortisolism is as high as 23 to 27%. And in our own surgical series of more than 900 patients with adrenal hypercortisolism that we operated on over the last 4 years, about 69% have mild disease, 21% have moderate disease, and close to 10% have the classic severe Cushing's syndrome. And with the radiological subtype, we also deal with benign disease and malignant disease. We deal with unilateral and bilateral, unifocal and multifocal, and macronodular and micronodular. So in panel A, you have the classic adrenocortical carcinoma, overproducing cortisol, causing severe Cushing syndrome. In panel B, you have the classic PRKA mutant adenoma on the right side, and you can even see that atrophic contralateral gland, the white arrow in panel B. You can hardly see that gland because it's been atrophied from the high cortisol levels. Panel C and D is the same patients that have bilateral adenomas with moderate hypercortisolism, and panel E is the classic bilateral macronodular adrenal disease with tumors on both sides. And panel F, I think you can appreciate the muscle wasting in this patient who has severe Cushing's syndrome due to an inherited mutation causing PPNAD. So we're dealing with all these radiological subtypes, and of course each of these patients need treatment that's tailored. And that brings us to treatment. The surgical options in adrenal hypercortisolism are dependent on the preoperative adrenal hypercortisolism subtype. So after the patients undergo cross-sectional imaging, typically with adrenal protocol CT scan, we then divide them into one of the pathological subtypes. And the surgical options you can think of, divide them into conservative, aggressive, and the more aggressive, that means the less adrenal tissue I preserve. So for a typical adenoma, you could either do a partial unilateral or total unilateral. But for patients with bilateral adenomas, you could do bilateral partial adrenalectomies or total unilateral adrenalectomy on one side and a partial on the other side. The whole point is to preserve at least 30% of adrenal tissue to avoid adrenal insufficiency or postoperative permanent hypocortisolism. So for instance, in bilateral macronodular disease, often we operate, like in this patient, on the dominant gland first, and then, dependent on the biochemical response, decide whether to do a partial resection on the other side. And for severe Cushing's, for instance, in PPNAD, sometimes we remove all adrenal cells. You can think of it as the surgical equivalence of block and replace, like you get rid of every adrenal cell, and then of course those patients need to be replaced with hydrocortisone and Florinef the rest of their lives. And of course in the setting of adrenocortical cancer, complete R0 en bloc resection of the entire cancer is important. And in close to 2,000 adrenalectomies, our preferred approach is the mini-back scope adrenalectomy. Our surgical volume represents about 12 to 14% of all cases in the United States. And we found this operation to be better, faster. It takes about 15 to 20 minutes in non-obese patients. And that's because the adrenal gland are located in the retroperitoneum, and using a mini-back scope approach, we get right to the adrenal, whereas if you go through the belly, you have to move both load of different organs just to get to the adrenal gland. So the length of stay is shorter, recovery is faster, there's less dissection, less pain, superior cosmesis. And because we don't go through the abdomen, if they had previous intra-abdominal operations, we don't need to deal with that scar tissue, those adhesions. And it's particularly well suited for function-preserving surgery. So this is an intraoperative picture. On the right side, you have the IVC in the background. You can see the cortex and the tumor that I'm removing. And I think you can appreciate all those tiny little veins and arteries that supply the normal remnant. So again, as long as we can preserve 30% of a gland and all those fine little supplying arteries and veins, that remnant will heal and function just fine. And here you can see the resection margin. So compared to other operations like laparoscopic or robotic transabdominal operations, as you can see, the operation provides direct access with shorter operative time, faster recovery time, less pain. The big limitations, if you have a really large tumor, you have less working space, and for low volume surgeons, this is often an unfamiliar operation, so it requires some extra training. So here are again some examples how we think about the surgical options. The first panel, ABC, is the same patient, so has a unilateral right adenoma, again with an atrophic contralateral gland, pretty straightforward. Patient has a total unilateral operation. But the patient DEF is a patient that has bilateral adenoma, so we do a partial resection on the right side and then a total unilateral adrenalectomy on the left side. Again, preserving at least 30%. And the GH is a patient with BMAD, bilateral macronodular adrenal disease. Again, total unilateral adrenalectomy on the left side, partial resection on the right side. Again, sort of the block and replace variant of adrenal surgery is a patient with severe Cushing syndrome, again with PPNAD, where we elect to remove both adrenal glands and supply glucocorticoids the rest of their lives. And the last case is a patient with a cortisol-producing adrenocortical carcinoma, and the white arrow indicates a tumor thrombus that obviously has to be resected as part of the operation. So there is a tumor thrombus in the left adrenal vein. So, of course, a lot of patients are not immediate candidates for surgery, and in some patients, surgery is never going to be feasible. So that's where the role of medical therapy in adrenal hypercortisolism comes in. So a common thing is patients unfit for general anesthesia, for instance, if they have had a recent cardiovascular or neurological event. And number two, neoadjuvant preoperative therapy. We often think of neoadjuvant therapy in the context of cancer, but it just means preoperative, preparing the patient for surgery. And if you think about it, we use neoadjuvant therapy in endocrinology all the time. For instance, using alpha blockers in preparation for a pheochromocytoma resection, or using MRAs and antihypertension in the PA patients to control the hypertension and the hypokalemia in preparation for surgery. So that's sort of the concept of neoadjuvant therapy in adrenal hypercortisolism. So the most common indication we see is for patients that have morbid obesity until they reach a goal weight. So it's a completely different operation to operate on a patient that has a BMI of 40 than even compared to 35. And that's regardless which operative approach you use. So often if the BMI is greater than 40, those patients go on cortisol modulating therapy in preparation for surgery. Those with poor metabolic and symptomatic control from diabetes and hypertension, and maybe to reduce transient post-adrenalectomy hypocortisolism. We need much more data on this, but at least it makes physiological sense if you can restore the HPA axis somewhat preoperatively. Patient may have less issues post-operatively. Again, studies needs to be done in that field. Certainly for patients with persistent or recurrent disease where remedial surgery is not warranted, patients with limited life expectancy, and when surgery is otherwise not feasible or is declined. And I put here with 3 question marks. I don't think anybody knows really how to manage these patients best, but what about those patients that have clearly biochemical adrenal hypercortisolism, but they don't have any structural disease? Some people in the literature use non-neoplastic adrenal hypercortisolism. I'm not crazy about that terminology, but bottom line, you do a CT scan and there's no visible abnormalities on the adrenal gland, and that might be as high as 60% of the cases. We just don't know how best to manage those patients. So what are the medical therapies for adrenal hypercortisolism? Well, 2 major groups, the glucocorticoid receptor blockers, mifepristone, and the steroidogenesis inhibitors, osilodrostat and levoketaconazole. Those 3 are the ones that are licensed. But then off-label, ketoconazole, metyrapone, mitotane, etomidate, the last 2 mainly in the acute setting or in the setting of a cancer, but those are certainly being used. So in summary, adrenal hypercortisolism is very common, undiagnosed, undertreated, and even in the mild cases cause significant harm. And I would say I have the best job in the world as an adrenal surgeon because I get to see patients like this. There's a patient with a young patient with adrenocortical adenoma, but severe Cushing syndrome, and of course a remarkable effect. So that brings us back to our case. So today, to just recap it, so at today's visit, She's a little bit discouraged because her blood pressure was higher, her A1C had gone from 6.7 to 8. She regained some weight, about 15 pounds. Her DST, as we mentioned, had improved from 10, but it's still elevated at 5, and her ACTH is still suppressed. And she clearly, as she expressed, she did not want to have further surgery, and function-preserving operation was not immediately available to her. So she agreed to medical therapy. She was started on osilodrostat, 2 milligrams twice a day. A medical alert bracelet was recommended, and 3 weeks after initiation, she called to move up her appointment because she's experiencing concerning symptoms. And now her labs show a very high ACTH level. The cortisol is low at 6 micrograms per deciliter, and her LFTs remain slightly elevated.
So the next part will be scene 2.
Hi, Deanna. I'm glad you called and that we could get you in quickly.
Me too.
You mentioned on the phone you haven't been feeling well. Tell me what's been going on.
I've just been feeling really off for like the last 2 days. It's been rough. I'm exhausted and slept a lot yesterday. I'm pretty nauseous and I haven't really wanted to eat anything, which isn't like me.
Okay.
My muscles also feel achy, but it feels different than when they used to ache from the Cushing syndrome. I can't really describe it. I just feel completely wiped out.
I'm glad you reached out. Looking at your labs, your cortisol level came back at 6, which is below our threshold of 10, and your ACTH is elevated. This tells us that your body is now producing enough cortisol right now, so you have adrenal insufficiency.
Again, I had this after surgery too.
Yes. Your labs and the symptoms you're describing, the fatigue, nausea, loss of appetite, muscle aches, are all consistent with adrenal insufficiency. And we know this can be a side effect of Cushing syndrome treatment. The osilodrostat is working to lower your cortisol, but in your case, it has brought it down too far. Have you taken any glucocorticoid medication yet today?
Yes, I took the hydrocortisone tablets in the morning, but I didn't give myself the injection. I didn't feel as bad as I did after the surgery, so I wasn't sure if it was the same thing.
Yes, it is. Adrenal insufficiency can happen after surgery when one gland is removed to treat adrenal Cushing syndrome. This is usually temporary. It happens because your body's hormone system needs time to wake back up. Some Cushing medications can also cause adrenal insufficiency by slowing down the body's production of cortisol.
I see. So what can we do?
Since you have been tolerating the osilodrostat, otherwise my recommendation is to lower your dose to 2 mg at bedtime.
Okay. Do you think we should try another medication?
There are several medication options to treat adrenal Cushing syndrome. While switching to a different medication is possible, your live enzyme levels are currently a bit elevated. So I would prefer not to make a change to a different cortisol-lowering medication right now. Another option is a medication that blocks the effect of cortisol on your body's organs. However, with that type of treatment, we wouldn't be able to reliably measure cortisol levels. We will have to go by your symptoms and glucose levels.
Yeah, honestly, until this started, I was feeling fine on the new medication.
Okay. I'm going to have our nurse come in and teach you how to give yourself the glucocorticoid injection in case you ever need it. She'll also review your adrenal insufficiency protocol, including what to do on sick days, when to use the injection, and when it's important to go to the emergency room or call 911.
That would be really helpful. I think I was just unsure.
That's completely understandable, and that's exactly what today is for. I also noticed you have your medical alert bracelet on. That is really important, and I'm glad to see you wearing it.
Yeah, I got it like you suggested. Do you think that I'll feel better soon?
I do believe that taking hydrocortisone for a few days and lowering your dose of osalolodrostat will help resolve these symptoms. But please call us right away if things do not start to improve. And if your symptoms get significantly worse, inject the glucocorticoid and go to the emergency room. Don't wait.
Okay, I will. Thank you.
Of course, I'll send the nurse in shortly.
Okay, so now this takes us to the second part of this presentation, which is focused on medical management. But also throughout this, I would like to give you my tips and tricks on how to monitor each therapy. So when do we consider medical therapy? As we already discussed a little bit, we generally consider medications when surgery is not an option or if the patient has declined it. We also consider it when disease persists or recurs despite having surgery, and that could be pituitary or adrenal, of course. And we also consider this when the patient has severe symptoms that are present and say at this point they're not optimized for their surgery, or when there's a medical emergency, and in that case medical treatment would be initiated. And then lastly, occasionally while we're waiting for surgery, or say if the patient had radiation to their pituitary residual tumor, we are waiting for that to become effective. So medical therapy rarely induces remission, and instead our goal is to achieve disease control while also looking at cortisol levels as well as clinical outcomes. So this is my decision flower on how to choose medical therapy. So as you can see, there are a lot of considerations that go into it, including what's the underlying cause, what is the disease severity. Also, we are looking at comorbidities, concomitant medications. Cost is a big consideration, efficacy, prior treatments. We are also looking at special circumstances, and lastly, but not least, patient preferences. So a lot goes into it. There's not a simple algorithm to follow. So I will just take you on a roller coaster ride of medical therapies for adrenal Cushing, and this is meant to provide a summary of efficacy of these medications, not to be an exhaustive literature review. So just briefly, ketoconazole inhibits 17-alpha hydroxylase, 11-beta hydroxylase enzymes, which blocks adrenal androgens, cortisol production. It needs gastric acid for absorption, so patients who are on PPIs, for example, might not be optimal candidates for ketoconazole. It has pretty rapid onset of action, and from the studies, it normalizes urine-free cortisol in up to 50 to 60% of cases, but the range is quite wide. So safety is important to keep in mind when considering this. For example, the patient that we were discussing here had mildly abnormal liver function tests, and hepatotoxicity is a big consideration for levoketoconazole and ketoconazole. GI disturbances are common. We also have to pay very close attention to concomitant medications due to drug-drug interactions. Adrenal insufficiency is a consideration for all medications for Cushing, skin rash, and as well as gynecomastia, hypogonadism in males. So when would I consider ketoconazole? Typically, this is a therapy we would consider for mild to moderate hypercortisolism, and then also potentially combination therapy when we are combining multiple agents, and also potentially in women who have hyperandrogenism. So just kind of going back to this scene and thinking, is this a medication I would probably start the patient with or not, and what would be the reasons for this? So the next medication is levoketoconazole, which is racemic ketoconazole. It's an enantiomer, and the advantage is that it's FDA approved for Cushing syndrome. It potentially has lower hepatotoxicity risk and improved side effect profile compared to ketoconazole. In terms of the normalization of urine-free cortisol, we see that in about 30 to 50% of cases, with improvements in cardiovascular and metabolic parameters. And I want you to know that I'm mainly talking about urine-free cortisol, which is oftentimes the primary outcomes for Cushing studies. We're not talking here about any other test that we can use for monitoring the disease control. So just this is a summary of efficacy of levoketoconazole in lowering urine-free cortisol. You can see that there was a pretty rapid reduction within 1 month, and that showed a sustained control in a 6-month follow-up period. So safety profile, once again, the most common side effects would be gastrointestinal, like nausea. Patients also experience headaches, hypokalemia. And then with LFT abnormalities or liver enzyme elevations that are typically more than 3 times above the upper limit of normal, that was noted in about 11% of patients, and this was reversible upon medication cessation. QT prolongation, about 10% of patients, and adrenal insufficiency risk is definitely not minimal. So for levoketoconazole consideration, again, I would consider this for mild to moderate hypercortisolism when combining with other therapies in women who have acne or hirsutism. And again, just like ketoconazole, I would also try to avoid it in men due to hypogonadism. The next medication is acylodrostat, and hopefully everyone is keeping up. But now we are moving to a potent 11-beta hydroxylase inhibitor, which blocks the last step of cortisol synthesis. And it's also FDA approved to treat Cushing syndrome. Typically, the label calls for 2 milligram twice daily dosing, which is what our patient was initiated on. But from additional data, it seems that initiating at the lower dose and incrementally changing the dose might be beneficial in terms of response, but also tolerability. It has a rapid onset of action and has a urine-free cortisol normalization up to 86%, which is probably the most potent medication for Cushing syndrome we have to date. And I wanted to share this data to show you a comparison and contrast between LINK-3 and LINK-4, focusing on patients who developed hypocortisolism-related syndrome and symptoms. And as you can see in LINK-3, there was a much higher prevalence of adrenal insufficiency type of symptoms compared to LINK-4, although the doses were similar. The difference was how quickly the medication was titrated. By forcing titration and moving rapidly, patients tend to have more of these side effects as shown in LINK-3, as opposed to as liberating, relaxing the titration period, following the patient more closely with symptoms, that tends to be tolerated better. So that was kind of one highlight that I wanted to show. In terms of safety, again, we are blocking 11-beta hydroxylase enzyme, which then leads to elevation of precursors. And this would be elevation of mineralocorticoid precursors like 11-deoxycorticosterone. In high concentrations, these are potent mineralocorticoids, which can lead to downstream hypertension, hypokalemia, edema, also nausea, anemia, headaches, as well as QT prolongations, and as I mentioned, hypokalemia was noted. And in a pooled analysis, adrenal insufficiency was reported in about 15% of cases. So it's a potent medication. And when would I consider it? So again, this patient opted for this medication. Typically, this is something we would consider for moderate to severe hypercortisolism because of its potency. We also will talk a little bit about block and replace strategy, and this is another time when I would consider it. It has a wide range of doses, and again, that gives it an advantage depending on how severe Cushing is. And hyperandrogenism, although it's a theoretical concern, it doesn't seem to be a major clinical concern, but certainly with accumulation of androgens, we follow those side effects. Methyropone is another 11-beta hydroxylase inhibitor, which again blocks the last step of cortisol biosynthesis, has a very rapid onset of action. Typically, after an hour of giving the dose, we can check cortisol, serum cortisol, to see how effective it is in lowering it. So this is something we would use in the hospital, for example. From some limited data, urine-free cortisol normalization was noted in about 50 to 75% of patients, but also escape in about 18%. It is off-label in the US, although it is approved in Europe. And unfortunately, this is a big limitation for us in clinic because without FDA approval, oftentimes insurance says, you know, they don't want to cover it. So that's a big limitation. Also, if you have had experience with it, it's a big pill burden with 3 times a day, 4 times a day dosing. So usually it's like a cocktail of medications throughout the day that the patient has to take, but it works very quickly. It has been reported to be used in pregnancy without apparent adverse effects. Major side effects would include GI upset. So this is a medication, I would say, make sure you take it with milk or a snack to help with that. Also, we are concerned about accumulation of androgens and mineralocorticoids, just like with osilodrostat, with downstream symptoms of hirsutism, acne, hypokalemia, edema, and hypertension. Also, patients report fatigue, and adrenal insufficiency prevalence is very close to osilodrostat, about 12%. So again, I do consider it especially for hospitalized patients when I need to lower cortisol rapidly. But the patient is not quite unstable to initiate something like etomidate infusion. So very rapid onset of action. We like to use it in certain cases for preoperative optimization or as bridging therapy when patients are considering pregnancy. And also it has a pretty wide dose range. And last but not least is mifepristone, which is a different type of medication. It's a glucocorticoid receptor antagonist that unfortunately also antagonizes progesterone and thereby causes some adverse effects. It can cause endometrial thickening, and it's been shown to improve hyperglycemia as well as improvement in Cushing-related clinical symptoms. So based on the evidence, mifepristone is studied mainly in patients who have Cushing, but also with type 2 diabetes or hypertension. Those are the pivotal studies. And in this situation, we cannot follow cortisol levels because this is a glucocorticoid receptor antagonist. So now we are looking at clinical outcomes like glucose lowering. And in this study, 60% of patients had at least a 25% improvement in their glucose area under the curve on 2-hour glucose tolerance test. Also, what's important is that fasting glucose decreased from 149 to 105, so this is a remarkable improvement, clinically and statistically significant. And additionally, 38% of patients had at least 5 millimeter per mercury reduction in their diastolic blood pressure. And these are just graphs showing you area under the curve, depending on the duration of therapy. So you can see that that graph is trending down, falling down nicely, showing reduction in area under the curve on the test. Safety and monitoring are important. It is FDA approved for hyperglycemia or diabetes in Cushing syndrome. So this is certainly not a medication I would consider if the patient does not have hyperglycemia or diabetes with Cushing. We cannot use cortisol levels to guide therapy, so we have to go by by glucose and other clinical outcomes. Adverse events include hypokalemia, nausea, fatigue, and joint aches. And also this is contraindicated for pregnancy because it induces abortion. So how do we monitor? Again, we are following clinical response only in this situation. We are looking at at glucose control, as well as weight, edema, mood changes, and blood pressure, as well as other comorbidities. And of course, a very infamous study that I cannot give a talk without mentioning is the recent data on Catalyst. Part 1 was the prevalence study. I'm focusing on part 2 here, which was this treatment phase, which was a randomized placebo-controlled study. And all adults in the study had uncontrolled type 2 diabetes, along with abnormal 1 milligram dexamethasone suppression test. And primary endpoint was change in A1C from baseline to week 25. And you can see that placebo pretty much stayed flat, as opposed to treatment with mifepristone induced this rapid improvement in A1C level at 3 months of follow-up, and that continued to trend down at week 24 as well. And these certainly were clinically and statistically significant results. So mifepristone, I would consider certainly if the patient has associated hyperglycemia. Also, if I would be okay and the patient would be okay not following cortisol levels, but rather going by symptoms, sometimes that's favorable when you don't have labs nearby, for example. And then also that might be an advantage to some physicians and also patients not to have to follow cortisol levels. So in terms of therapeutic goals for Cushing syndromes, as endocrinologists, we love labs. So we love to say, well, the labs look great, especially you see that the studies are designed to follow urine-free cortisol levels. So definition of fully controlled syndrome does, of course, take that into account. Biochemical control is important. But we also have to focus on normalizing and improving Cushing-related comorbidities. So with that said, biochemical control without clinical improvement is not true remission. So we are looking then at biochemical control, which is when we follow cortisol, unless it's a mifepristone. We also are thinking about maybe we need to look closely into restoring cortisol circadian rhythm. A clinical improvement, this is when we are assessing patients' weight, body composition, their blood pressure, glucose, skin changes, and also muscle strength. And then certainly part of this, when we are treating with medications, we have to follow adverse effects very closely. And specifically, those will be adrenal insufficiency for all these medications, but also metabolic labs, liver enzymes, QT changes, hirsutism, acne, edema. So there's a lot that goes into it. So just again, a very broad overview of how I look at labs. Urine-free cortisol is helpful to use for monitoring if the patient had abnormal urine-free cortisol at baseline. Of course, this is not the test that I would use if the patient had normal cortisol, like on our patient's labs when she came back for her 1-year follow-up. And basically, urine-free cortisol tells us about total cortisol secretion in a day. And it is a primary monitoring test for all available clinical trials, and it's not something that can be used with mifepristone. Limitations would be that it's not useful for adrenal insufficiency, and it also, of course, requires accurate collection. And as I mentioned, if the cortisol, urine-free cortisol was normal at the diagnosis, it's not helpful then to monitor it. That's the limitation. Late-night salivary cortisol, again, we're talking about monitoring on medical therapy. This tells us about loss of diurnal cortisol rhythm, and with treatment, we are hoping to restore it. So cortisol should be nice and robust in the morning and very low at nighttime. And it's often used as a complementary test to urine-free cortisol. So oftentimes, once I normalize urine-free cortisol, I start to add late-night salivary cortisol to help me then see that patient a little bit more closely in terms of their biochemical recovery. And we have to consider different assays, collection variability. Morning cortisol, I like it because it comes back so quickly. I get it the same day, and it's also very informative about adrenal insufficiency risk. So typically it doesn't tell me if I'm controlling Cushing, but it tells me if the patient is at risk for adrenal insufficiency, which you saw with our case. Her morning cortisol was only 6 with high ACTH level. At this point, she's already self-conducting cosentropin stim test, so we know that this is maximal adrenal reserve, and we have to treat this adrenal insufficiency. So another aspect of serum cortisol is when we are trying to differentiate between glucocorticoid withdrawal syndrome and adrenal insufficiency. Because if I see that morning cortisol is 11, then probably the symptoms are closer to glucocorticoid withdrawal symptoms. Then we reassure that patient. But if cortisol is low, then that's when I would suspect adrenal insufficiency as a primary etiology. The symptoms are so superimposed that it's hard to go by symptoms to differentiate from adrenal insufficiency and glucocorticoid withdrawal. And then plasma ACTH, sometimes it's helpful, say for pituitary or ectopic cases when we can see ACTH as a marker of tumor activity. Also, it can be useful for ACTH-dependent Cushing syndrome to monitor disease, detect overtreatment, like in our case, but it has very high biological variability. So, again, now we are shifting to clinical response beyond urine-free cortisol, beyond cortisol measurements. So the important aspects to this would be to improve these key clinical endpoints, which would be weight and body composition. Of course, we want to improve blood pressure, glucose control. Psychiatric symptoms are commonly a huge issue. We are also aiming to improve patients' quality of life, which is becoming more and more part of clinical research and critically important to assess that as a treatment modality. And then muscle strength as well as physical phenotype changes. So we try to treat the patient, not just their cortisol number. And of course, that's what makes those visits pretty complex and requires a lot of attention to detail. So in terms of monitoring, again, I usually compartmentalize it to when I'm using adrenally directed agents versus glucocorticoid receptor antagonists. And ultimately for medications like ketoconazole, levoketoconazole, but also metyrapone, and lastly osilodrostat, I kind of listed them here as a laundry list of common issues, but I already went over this in great detail, so I usually like to look at this side by side depending on what medication I'm using. Sometimes if it's a combination, then I really have to follow those patients closely depending on a biochemical profile and mechanism of action. All agents induce risk for adrenal insufficiency, and it's not minimal, but also some common GI side effects, medication interactions, and none of these are approved for pregnancy, although metyrapone has been shown to be safe in some cases. Now, shifting to glucocorticoid receptor antagonists, cortisol remains elevated on this therapy, but it blocks the effect at the receptor level. And again, main issues would be downstream effects of glucocorticoid receptor antagonism, but also progesterone receptor, which becomes a problem. That's when women can experience endometrial thickening, vaginal bleeding, and that may require further evaluation with an ultrasound and sometimes biopsy. So, and of course, cost is a big consideration for all of these medications. And again, it is contraindicated in pregnancy. So just in terms of, again, looking at different classes, comparing safety between these classes, when we are thinking about glucocorticoid receptor antagonism, we are thinking about titrating the dose slowly to prevent glucocorticoid withdrawal syndrome. If we suspect adrenal insufficiency, we can't really check cortisol levels in this situation, so that becomes more challenging. And if we are treating the patient for adrenal insufficiency, please make sure to remember to double or triple their glucocorticoid replacement to counteract the effect of receptor blockade. Monitoring for hypokalemia is also important. And then we are talking about steroidogenesis inhibitors when overtreating can cause adrenal insufficiency, which we monitor with labs and clinical symptoms, also QT prolongation. With osilodrostat, metyrapone, also we have to monitor for adrenal hormone precursor accumulation, and levo and ketoconazole, hypogonadism, and gynecomastia. Okay, so very critical part of this talk is how to monitor for adrenal insufficiency. And as I mentioned, there's a high risk of adrenal insufficiency with all of these agents. And typically the patients are more susceptible to adrenal insufficiency when we are escalating the dose, but also when we are combining therapy. Certainly we look for fatigue, weakness, nausea, hypotension, anorexia, and typically morning cortisol can be very helpful in differentiating glucocorticoid withdrawal syndrome from adrenal insufficiency. So it's extremely important to have that education with the patient, to teach them how to recognize symptoms of adrenal insufficiency. They have to have medical alert monitor, medical alert ID, as well as glucocorticoid injection, and I usually prescribe a bottle of pills of hydrocortisone and teach them on sick day guidelines. So planning for safety is very important. And just in terms of diagnosis, if symptoms are mild, say the patients are on medical therapy, but symptoms are mild, and we are suspecting biochemical oversuppression, like in our patient, we typically lower the dose, and or sometimes we would temporarily hold it. Again, this is in a context of mild symptoms. If symptoms are moderate, then we typically hold the dose and also start glucocorticoid replacement. And then lastly, if symptoms are severe or the patient has a severe illness or crisis, that's when the patient would be injecting glucocorticoid, like any of the type of glucocorticoid to treat adrenal crisis. I already alluded to this, that glucocorticoid withdrawal syndrome is not the same as adrenal insufficiency. Very different definitions and mechanisms, but symptoms overlap, which makes it very challenging. And ultimately, we cannot avoid glucocorticoid withdrawal syndrome. So this is a part of the discussion I have with the patient up front before surgery and before their medical therapy to prepare them for this. And ultimately, the way I describe this, that these patients will have symptoms, but the symptoms should be tolerable. They should not be incapacitating that patient. And then I use cortisol levels to help me monitor for adrenal insufficiency in this context. To treat these, for glucocorticoid withdrawal syndrome, we certainly reassure the patient. We tell them to eat good protein diet, gentle exercise, supportive measures. Sometimes they take NSAIDs for pains and aches. But ultimately, we try to then go up a little bit on glucocorticoids, knowing that also might potentially prolong their recovery. And we don't really have good data on whether any of these interventions work. And then, of course, for adrenal insufficiency, that's when we want to initiate physiologic glucocorticoid replacement, educate patients on adrenal action plan, and provide them with education, supplies, etc. So also just in terms of how we treat, so there are different strategies to this. The first one is titration method, when basically we're looking at normalizing cortisol levels. So we typically adjust the dose to normal cortisol levels, and the first one would be to bring urine-free cortisol in the normal range and then add late-night salivary cortisol to that, along with morning serum cortisol to look for adrenal insufficiency. Block and replace can be considered, but typically we aim to completely suppress morning cortisol as well as urine-free cortisol. This oftentimes requires higher doses, and once cortisol is low or is becoming low, that's when we start glucocorticoid replacement. We would consider this in patients who have severe Cushing or cyclic Cushing, or patients who have adrenal cortical cancer. That would be my consideration when we are trying to just normalize their cortisol levels by this block and replace method. And then lastly, when we consider changing one agent to another, typically this would be something I would consider if their hypercortisolism persists despite 2 to 3 months on maximally tolerated dose. Also, if they have partial response, I would consider potentially combination therapy. Certainly, if side effects are not manageable, we would consider switching an agent. And then with this escape phenomenon, we try to reassess, adjust, potentially switch their therapy. So back to our exam room. At the follow-up visit, this is a patient's ACTH is very high, cortisol is low, plus she has symptoms of adrenal insufficiency. So we discuss options in this situation to reduce her dose of acylodrostat by doing this chronotherapy approach, by giving them the dose only at nighttime to bring their nighttime levels low, and also to allow morning cortisol to be nice and robust. We also discuss glucocorticoid injection in certain situations. And then at 9 months after starting treatment, the primary care doctor calls the endocrinologist, which I guess will be me, after her annual appointment, and the primary care doctor notes that her blood pressure is still elevated. Her A1C improved, but still remains above the goal at 7.2, and her weight decreased, BMI decreased to about 38, from 38 to 35. Her cortisol levels have normalized. Aldosterone is 11.
And with that, I know you're wondering if I talk. I do. I promise. Okay. Comedic relief there. Great job, Dr. Hamidi. But now, last but not least, let's move over to scene 3.
I want you to know I had a chance to speak with your primary care physician after your recent visit with her. She mentioned that your blood pressure is slightly elevated.
Yeah, she told me she was going to call you because it's still been running high.
Okay, before we get into that, how are you feeling overall?
Honestly, a lot better than I did a year ago. The brain fog has lifted. I've lost some weight. I'm sleeping better. It's just my blood pressure. I just don't understand. I had the surgery and I've been on medication. So why isn't everything back to normal?
That is such a fair question. And I want to make sure I explain this clearly. Your cortisol levels have normalized, which is a real success. And your weight loss and improved energy reflect that. But with Cushing syndrome, although cortisol levels are currently well controlled under the current drug, some of the long-term effects of prior cortisol excess, such as high blood pressure and elevated A1C, may persist and do not always normalize right away. These conditions often require continued targeted management independent of cortisol control. We expect improvement, and we have seen improvement, but a complete cure of everything isn't always achievable with Cushing's management alone.
So my blood pressure will just always be high?
Well, not necessarily, but there's another piece to this. You also have a primary aldosteronism, which is a separate condition that often coexists with adrenal Cushing syndrome, and it frequently persists even after cortisol is normalized. Your aldosterone level is currently at 11, which is lower than before your surgery, but it's still higher than we would like and is probably contributing to your high blood pressure.
So what can we do about this?
Our goal moving forward is to optimize your blood pressure and glucose levels alongside maintaining stable cortisol levels. Your PCP and I would like to start you on a medication, a new one that helps lower blood pressure called spironolactone and specifically targets aldosterone. We think it could make a real difference for you. We also need to review your current medications for diabetes and consider adjusting them or adding a new agent to help get your sugars under better control. Are you open to trying it?
If you think it'll help, let's try it.
Great. I'll have the nurse come in to go over the new medication with you and answer any questions.
So, very interesting case here as we wrap it up here in the long-term management of Cushing syndrome, and that's always the challenge in clinic. A lot of these patients, especially what we've seen in the newer development and the evolving state of hypercortisolism with our newer studies that are coming out showing the prevalence with type 2 diabetes and hypertension, the struggle becomes being able to manage this patient, and it becomes a chicken or the egg approach. So we're going to talk a little bit about that long-term management, either post-surgery or with medical therapy, and look to see how we can remedy that. But when we think about surgery, it is powerful when definitive, but it's inconsistent when it's partial. And again, this is looking back at a paper in 2017 in these patients with Cushing syndrome and looking at the prevalence that was improved after bilateral adrenalectomy. Again, now we're knocking out both adrenal glands here, so again, we're going to have to replace these patients with steroids, mineralocorticoid, glucocorticoid, etc. But definitely we had an improvement. We see the significance in the hypertension and in diabetes. However, these comorbidities can still coexist for other reasons. So again, bilateral adrenalectomy delivers complete biochemical remission. I mean, there's no more adrenal gland, right? But it creates lifelong adrenal insufficiency trade-offs, which we have to be very transparent with the patients. And again, I think both Dr. Carling and Dr. Hamidi, really rectified this to say it also involves that patient-centered care. Unilateral adrenalectomy often leaves heterogeneous control and limited comorbidity reversal. And lastly, a medical option that approaches bilateral adrenalectomy efficacy without irreversible endocrinopathy would be highly differentiated. Okay? Now, when we look at overt adrenal Cushing's in comparison to MAX, that fun, mild, autonomous cortisol secretion that's gaining all the buzz of recent, right? This is after source control. And as you can see here with overt Cushing's, much, much better, resolution rates. And to be truthful, if you have a unilateral adenoma that's producing cortisol, you remove it, get rid of the problem, these patients can respond much more favorably. In MAX, a little bit difficult to discern. You're not seeing that same response. So again, not all downstream disease is reversible once cortisol is normalized. Again, diabetes can exist for a multitude of different reasons. Beta cell dysfunction, adiposity, sarcopenia, vascular remodeling. These can outlast the cortisol excess as well. And again, you're not adding any favors to it when these patients are struggling with hypercortisolism. And lastly, this just supports a parallel treatment model. Control the cortisol, but you also have to independently treat cardiovascular and metabolic sequelae. I think we all deal with this in clinic, no? I mean, everything that we looked at, even in the clinical studies in the diabetes realm, still revolve around CVOT data. So it's something for us to keep in mind and think of that patient in that wholehearted way. Again, to quote the infamous DeFranco, right, the ominous octant, the noxious non-tuplet, all these different disease states that can affect the beta cell in general when we talk about diabetes alone. Now, with the treatment model, we cannot stop at just cortisol control. It is going to be a huge part of this. But one, we deal with endocrine source control. We have the adrenalectomy for the overt adrenal Cushing's. Maybe we individualize surgery for MAX, potentially a unilateral adrenalectomy with maybe a partial resection of the other gland. But lastly, also medical endocrine therapy when surgery is not appropriate. Then we look at this from a risk factor treatment. I think nowadays when you go into that patient case, we're looking at to see what their comorbidities comprise of. I'm walking in, seeing what their BMI is, what is their diabetes, hypertension, dyslipidemia. We have the cheat sheet in front of us before we walk in the EMR. So again, making sure that we're optimizing those therapies as they're coming through. And I know we all know about the fun ones that, in the incretin agonist world, and then you hear about the rats lately, okay, with the peptides that we're having to deal with. Again, a little jokingly aside, but we need to optimize these medical therapies to be able to help these patients to prevent the sequelae of cardiometabolic disease. And lastly, one that gets, forgotten, bone protection and fracture prevention. It's, well known that osteopenia and porosis have a high prevalence in patients with Cushing syndrome and Cushing's disease in general. And of course, the longitudinal follow-up. And I think Dr. Hamidi did a great job in being able to understand and assess the HPA axis, making sure we're, not running into adrenal insufficiency or those glucocorticoid withdrawal symptoms, but more importantly, just being able to follow that for the patient. Again, we can track the other measures as well too. Blood pressure, A1C, weight, fractures. Most importantly, one metric that we never get graded for, quality of life. We think about these patients and they really can escalate, their quality of life significantly. And not only that, but we use it in unison, right? We escalate non-endocrine therapies when that residual disease persists. Again, it's separate but essential. We talk about the incretin agonists, all the buzzword, if you can get it past, the insurances or they got the cash to pay. Right? Then you think about the SGLT2s and the CV diabetes therapies as well. And of course, your old reliable antihypertensive statins, PCSK9s, etc., as well as your osteoprotective treatments as well. So why do the comorbidities often persist even after endocrine success? I always like to quote the infamous, Dumb and Dumber movie, okay? Follow me here, right? But when we think about surgery, we're looking for that adrenal, insufficiency shortly thereafter, right? And that's that moment where they prank the guy and they put chilies in his burger, and then he keels over and they all just jump and laugh at him because they played a big goof. But in reality, that's what we're looking for, especially as endocrinologists. It makes me happy when I see that patient who's adrenally insufficient the next morning. Maybe not so much for the patient, but we know it's more in that curative way. So again, something to think about, but they can still persist with these comorbidities. That deals with long-standing visceral adiposity, beta cell dysfunction, as well as the diabetes chronicity, vascular remodeling and endothelial injury, the bone microarchitectural damage, and lastly, all the significant background risk, age, obesity, OSA, CKD. Just think about our clinics. I mean, it's no longer a simple diabetes visit anymore. You're looking and you're assessing for hepatic steatosis, you're looking for OSA, you're trying to find the next watch pad, or where can I get my next sleep study done? So, I mean, these visits can be very complex, but these patients need our help. So what does that mean from a clinical translation standpoint? A patient can be biochemically better, but they still need intensive cardiovascular, diabetes, weight, and skeletal management. So the job's not done. And that doesn't mean it's a treatment failure. It's just an expected disease biology, okay? So with adrenal Cushing's and MACs, this is a really great paper by Nowak here in 2026, and this was in The Lancet. This is where cortisol control helps, but cardiometabolic risk still drives those outcomes. And out of the 629 patients, as you can see, 71% of them had hypertension at baseline. 28% had diabetes. And of that, 18% already had a cardiovascular event history, something we're trying to be proactive with, but sometimes we're still behind the eight ball, even as proactive as we are. So let's dive in a little bit more into the study. Right, so the median age was about 62 years, which is still young, right? So I tell my patients I never use the O word in clinic, but it rhymes with mold, okay? Female predominance at 68%. We talked about the prior CV events at 18%, hypertension at baseline and diabetes. But look at the treatment patterns, right? Cushing with surgery is 81% unilateral, 48% with bilaterals, 33%. Now we look at MACs. We talk about conservative, right? We're trying to treat the comorbidities, the underlying comorbidities. That was done 73% of the time. So obviously selection bias slightly in the MACs patients. But again, it gives us good raw data. Surgery, 21%, and 8% medical. And I know what you're thinking, that doesn't add up to 100. I thought the same thing too, but it's the way the data was comprised of the patients within the groups. And look at that median follow-up, 6.8 years, so almost 7 years of data. But look at the significance, the distribution in the phenotype, and this was, again, looking at surgical versus conservative management on cardiovascular outcomes in patients with bilateral adrenal tumors and cortisol excess. Look at the predominance in MACs, 83% in comparison to Cushing's at only 17%. So it tells us about this evolving, the spectrum of the disease of hypercortisolism. Again, MACs is common, it's morbid, and it's undertreated. I think Dr. Carling mentioned that right off the bat. But when you look at these patients, even in comparison to Cushing's, we give, a lot of that push towards Cushing's, as you can see the high prevalence in hypertension, diabetes, dyslipidemia, et cetera. But MACs doesn't fall right far from it. But yet it's probably easily missed in clinic because it leaves us always in that clinical conundrum, right? I have a biochemical test positive in the DST, but sometimes some of my other markers, such as the 24-hour urine or the late-night salivary cortisol, may not correspond. And just to add to this, another prevalence report, this was 46 studies, systematic review, meta-analysis, over 17,000 patients with MACs. And look at the significance there, 63% hypertension, 29, almost 30% with impaired glucose metabolism. Not even just fully saying diabetes. We're just saying this is somebody already with a bad home IR greater than 2, right? And then with dyslipidemia at 40, 41%, and obesity at 38, 40%. It's funny how sometimes we associate obesity, but yet sometimes it's the non-obese patient that has a higher likelihood for Cushing's. But again, MACs is often, it lacks that overt phenotype, but it carries the real hypertension, diabetes, and CV burden. So something, we do in clinic is when we look at these patients, don't necessarily go for the phenotype. Look at them for what they have for their comorbidities. Even if their BMI may be 26, but it's sitting in front of you with diabetes, hypertension, dyslipidemia, and a cardiovascular event, which we call in the Rio Grande Valley, the Valley Triad, the Valley Quad, right? It makes it easier on rounds. More importantly, that should raise up that suspicion a little bit. Again, conservative care leaves cortisol biology unaddressed. Not trying to beat, a dead horse here, but you always hear that term, maybe the influencers might say the whole, get to the root cause of the problem. But in these cases with Cushing's and MACs, cortisol is a root problem that we need to address, but it may not fix everything, okay? And lastly, guideline language remains individualized, creating treatment inertia. It's very difficult. You can get us all in a room here right now. We can start throwing out all the definitions between mild, moderate, and severe Cushing's, and we all might have a little different variances. But that's what makes it so, grand in being able to help and identify this disease state. Now, with adrenalectomy in MACs, the benefit is real, but it's often partial. And again, what does the evidence say? In these patients with MACs, hypertension does improve, and so does diabetes. And this was in a PROMISE trial. This was 12 months after surgical remission. It was 51% hypertension, 37% diabetes is the pictorial there, right? But again, the strongest quantitative benefit was for systolic and diastolic blood pressure and bone outcomes, believe it or not, okay? So again, surgery helps. It definitely helps. I mean, that beautiful picture of that patient, you see them with that cushingoid, the moon faces, and she was beautiful then, beautiful afterwards. But more importantly, these patients can still persist for other areas as well too, especially in the MACs, category. So again, improvement does not necessarily associate cure. More severe baseline hypercortisolism predicts a larger reversal. So again, the acuteness of it as well. Now, chronotherapy. I know Dr. Hamidi was chomping at the bit about this, right? But it makes a lot of sense. This is the goal in patients with Cushing's. It's that loss of diurnal rhythm. These patients losing out and being able to have that beautiful, robust AM cortisol on that lower end in the evening. Or if you're like me with 4 kids with a newborn, I'm pretty sure I look like I'm cushingoid the whole day, okay? And so, yeah, we want to restore that normal cortisol circadian secretion. And second best, we want to get as close to normal as possible. So as you can see here, let's follow the trend, let's follow the wave, okay? So the active Cushing syndrome, you can see very minimal fluctuations here, right, in comparison to the norm, where you're going to have more of that high cortisol and that low cortisol in that sleep cycle, and you get that nice little wave, right? But more importantly, with medically treated Cushing syndrome, the hard part here in chronotherapy is that we're trying to get as best as possible. Sometimes we can adjust our dosing accordingly, maybe with the steroidogenesis inhibitors, but we may not still get that nice curvature, and that's what we're looking for, okay? So again, most studies are concentrated on achieving that normal 24-hour urine cortisol, but again, that is not equivalent to our circadian rhythm. And lastly, the closer we can get to chronotherapy, the better we're going to be. Now, there's ideas and thought process about potentially monitoring this more in a serial manner, but again, more studies need to be done for us to understand, that chronotherapy. But again, for us right now in the treatment of Cushing's, what reigns supreme? It's that clinically relevant endpoint of biochemical control, doing what's best in our part, from a surgical and medical management. As you can see here, makes sense, right? We take out both adrenal glands, it's 100%, right, remission. Now, when we do a unilateral adrenalectomy, we're not seeing as much of that success, right? We're only seeing about 24 to 27%. But with steroidogenesis inhibitors, that can get even better, right? 69 up to 96%. But when you look at this, and why does this matter? Because patients in remission or biochemical control, yes, they're going to have fewer CV events than those with uncontrolled cortisol excess. Absolutely, we're reducing down one of the major problems here. But again, this supports not only the endpoint strategies that prioritize normalization, but not partially lowering it alone. We know that it's going to take a village to be able to treat these patients. And lastly, biomarker-defined responders can sharpen value demonstration. As you can see here with MACs in these patients with unilateral adrenalectomy versus, conservative treatment symptoms alone, yes, you may see a little bit higher remission rates, but still look at the intermediate and the uncontrolled. Intermediate being either them having, one or the other positive as far as a DST or, urinary free cortisol. Uncontrolled, they both have both parameters that are not well. So again, still a high likelihood in that intermediate and uncontrolled population. So yes, is cortisol control necessary? Absolutely. But its cardiometabolic control is what makes it valuable. And you're using it as a stepwise approach and being able to get to these patients in a cardiometabolic way. So again, comorbidity burden max, like I shared with you in that slide, and I just want to reiterate it because I think it's that great, is the fact that there's a high prevalence of these comorbid symptoms and syndromes. Hypertension, dyslipidemia, impaired glucose metabolism. I always jokingly say I follow the dusty triad, okay? And you can steal that for all you want. But if I'm going into a room with a BMI of 27 or above with pharmacoindication for obesity treatment and or a BMI of 30, plus or minus hypertension, dyslipidemia, I'm screening that patient. You have a cardiovascular event, I'm going to screen you, right? You ask me to screen you, I'll think about it, but I might screen you again, okay? But again, it's because that cardiometabolic disease is common before intervention. So that post-surgical improvement often starts from a heavy baseline burden. And, And what I'm trying also not to say in that long-term management too is saying that, okay, so, with surgery and medical management, I'm not trying to say that we're deciding one. I'm saying it takes that approach to be able to normalize cortisol, and we need to do what's in the best interest of the patient, especially when there's a clear surgical cause. Again, progression to overt Cushing's is uncommon, but the main risk, of course, with MAX is the phenotype conversion, but persistence of the cardiometabolic injury. And we want proactive screening. It's easier to be able to screen these patients, and get them in that proactive state versus them having to see 4 or 5 or 6 specialists before they get that diagnosis, okay? But again, it takes a village. It takes a core interprofessional team members here. And I'll just highlight here that, of course, the endocrinologists, I don't know why they put us at the top. Yay, right? So we're at the top, right? We're overseeing the diagnostic process. We're figuring out the etiology. Is ACTH dependent, independent sometimes? Again, this is also going to be, with the primary care providers. Some, primary care providers are getting a little bit more, proactive in this approach. But again, this is where we also have to be, that guiding light for them as well too, because again, this is our specialty. With a surgeon, right, with a general or oncology, and this also radiates with the neurosurgeon as well too. This is what's going to help us to address whether it's an ACTH dependent or independent cause. Again, our APPs, very valuable. I have a wonderful, wonderful PA and NPs that work with me. Again, it's a collaborative approach in that stepwise fashion to be able to help these patients. Again, pharmacists, when we're dealing, if you were to ask me every CYP3A4 inhibitor, I couldn't do that. I'd fail that test, right? There's a lot of these little things that we have to be proactive with and make sure, and the pharmacist comes into big play here as well too. Psychiatrist and a mental health specialist, super important. A lot of these patients struggle. I'll never forget one of my first, fellowship cases where a man pretty much developed Cushing's, had transphenolial resection, and then went into just this abysmal state, lost his house, lost his job, lost his family, simply just because of the variability in his cortisol. And again, I think when I was leaving fellowship, he went from that adrenal insufficiency manner and he was coming back into recurrence. Just a really sad situation, and we want to prevent that for these patients. Of course, pathology, very important. You see all the germline and somatic mutations that can be very valuable and something that's transcending in our medical research. I talked about the PCP, and lastly, a dietitian and nutritionist. I know sometimes our patients are not very fond of that, but more importantly, it's to help them to be better, okay? And again, what are these roles? In general, we highlight it. We want diagnosis and localization of the tumor, okay? Treatment selection, long-term follow-up, again, what we're doing here, patient education and quality of life improvements. More importantly, that last bullet point, I want the patients to have a better quality of life. So what's the bottom line, okay? For my wrestling fans, I would say the bottom line because Stone Cold said so, right? But MAX is a large, undertreated population, has progressive risk under conservative care. Again, definitive surgery works best when it fully normalizes cortisol, but it's not scalable for everyone. Again, that is a treatment decision made between the physician and also the patient. Sometimes the best therapeutic opportunity is the one that reliably not only normalizes cortisol, but fits that multimodal cardiometabolic care pathway. And again, it's going to use a combination of therapies with some of these wonderful medications that we have in the metabolic space. And lastly, persistent diabetes, obesity, hypertension, right? Even bone disease should trigger additional targeted therapy and not therapeutic nihilism, right? So we shouldn't just say, oh, you know what, we treated the Cushing's, and now you have diabetes. I don't know why. No, we need to understand that it's going to take that stepwise approach to help these patients. So let's go over the case study recap. So at the 1-year follow-up visit, the brain fog is lifted. We've seen some weight loss. Patient's sleeping better. Yes, the blood pressure remains elevated. She had the coexisting primary aldosteronism. Aldosterone is at 11, better than 15, but still something that we need to deal with, especially when thinking about that reference range of 10 to 15. So what's the goal moving forward? Let's optimize the BP. Let's get the glucose levels under control and stabilize those cortisol levels. I know we're all thinking it when we looked at the initial case study. Y'all saw the metformin, the pioglitazone, and I know we're thinking, where's the incretin agonist? Right, but something that we can definitely, dive into. But more importantly, we can start spironolactone, for this patient to help with lowering the BP and targeting aldosterone. And of course, review those medications, make those adjustments, reduce that pill burden on the patient to help them going forward. So I pass it over to the wonderful Dr. Carley for the concluding remarks.
Thank you very much, Dusty. And so there's a few take-home messages, and I think we all can see that surgical management and medical management is not either or. They're really complementary to each other. And again, Cushing syndrome is not one-size-fits-all approach. It's very much personalized based on the biochemical disease severity, as well as the etiology, as well as the clinical severity. And same thing with drug choice, is less about the best drug, but more about matching mechanisms, urgency, and the patient's toxicity profile. And as you heard, you may need to adjust therapy and try other modes of actions, for instance, changing a steroidogenesis inhibitor for a glucocorticoid antagonist or vice versa. Persisting comorbidities may need optimization of their medical comorbidities. So, believe it or not, I have a little timer down here, and it has 1 minute and 30 seconds left. So, and we got in a boatload of questions. So, in 1 minute and 20 seconds, I'm going to ask one question for Dusty and one for Oksana. We'll start with Dusty. What are the most common reasons Cushing syndrome is missed or diagnosed so late in clinical practice?
Great question, Dr. Carling. I think more importantly, it's not so much the clinical inertia. I think ultimately, at times we're rushed in the visits, right? We have people saying that we need to see 25, 30 patients in clinic. But I think when we start to, specialize out these individuals, they have type 2 diabetes with hyperglycemia, type 2 diabetes with peripheral angiopathy, dyslipidemia, metabolic syndrome, et cetera. I think when we get away from looking at the phenotypical part of the patient and we look at them from their comorbidities and what they, and what they're struggling with at that point, I think this is where studies like, the infamous, Catalyst study, other studies like Link Care, Momentum coming through. I think when we start to guide it more toward the comorbidity screening aspect, I think we'll gain a little bit more of that prevalence. I think it's just getting away from the fear of the diagnosis of Cushing's and just being more proactive about it.
Yeah, thank you, Dusty. And one quick question for Oksana. This is a very specific one, but when you add spironolactone to mifepristone, what effects are you looking out for?
Yes, mainly it's a medication that could be very helpful to counter the risk for hypokalemia and edema. So oftentimes we actually initiate mifepristone with spironolactone, anticipating hypokalemia, which could be pretty severe. So spironolactone helps us with that, and also manage other hypertension and edema.
So with that, thank you so much all for attending. It's been a great session. I certainly enjoyed it a lot, and hopefully that you all did as well. Again, I want to thank the speakers, Dr. Luna and Dr. Hamidi, and thank you all. And I hope you enjoy the rest of the evening and enjoy the rest of the AACE meeting. Have a good night, everybody.